Thank you. So surgery for mesothelioma is a little pet project of mine for the last 25 years. I have disclosures because of my research in mesothelioma, but really none of those apply to this because it has to do with biomarkers. So if you're talking about surgery for this disease, what's the use of surgery in pleural mesothelioma? What are the present limitations in deciding which patient you're going to operate on? Why is there so much controversy about whether you do surgery in mesothelioma? And I guarantee you that controversy is going to be a heck of a lot less considering the WT1 vaccine trial. What are the types of operations for pleural mesothelioma, and who are they suited for? And what, if anything, should be combined with surgery for pleural mesothelioma? We're talking about in the operating room or before, not so much after. So obviously you can palliate mesothelioma with surgery, and the easiest surgery is to do a Pleurex catheter, and that's wonderful to do for trials as well as for the patient to get induction and to be able to be treated before they get an operation while they're getting their induction chemotherapy. Why is there so much controversy? I'm going to talk about the staging system, but the staging is horrendous. There really are no adequately powered randomized trials that says that surgery is not the way to go in mesothelioma, nor does it really commit to say that an extrapleural pneumonectomy is not the way to go in mesothelioma in certain situations. There are big operations in patients who are frequently in their 70s and early 80s, some late 60s. And up until recently, we really didn't know what an operation was called. Everybody was doing a pleurectomy, but everybody's pleurectomy is different from everybody's pleurectomy. So there were no standards, and that's really changed recently. And then there is this bias that certain people think you don't operate on mesothelioma, and that's fine. And there are certain medical oncologists who feel that you do gain some mileage. But it all depends upon the biology, doesn't it? And we don't know anything about who to predict the biology on at this point. And surgeons who do these operations are really only beginning to learn that the Boston idea of one operation fits all doesn't apply anymore. So here's really what it looks like. I mean, if you look at the different ways in which the pleura can be involved, I mean, you have early stage mesothelioma in which it's just on the parietal pleura or on the parietal and the visceral pleura, a little bit more extension to the diaphragm, then in the fissures, and then a little bit more with lung contraction and confluent meso around the lung, possibly involvement of the pericardium. And then obviously it gets worse with extension into one or more sites of the chest wall, outside the chest wall, and then involving the diaphragm and through the diaphragm. What was the trial that made everybody say surgery is no good in mesothelioma, or at least an extrapleural pneumonectomy, which was the favorite of many in the United States until recently when this came out? Well, this was a trial that was supposed to show that induction chemotherapy or chemotherapy alone was going to be the best thing for these patients. So what happened is that there was a randomized trial between preoperative chemotherapy versus preoperative chemotherapy and extrapleural pneumonectomy and postoperative radiation therapy to see in UK how this was going to play out. They started with 257 patients, and this randomized trial became a feasibility trial because only 50 patients got randomized. They all failed up to this point. But they randomized these patients, and what they found was that I don't have it, but the induction without surgery seemed to do better. Can I move that slide back one, please? Can you do that? Thanks a lot. The important thing is the 12% operative mortality. 12% operative mortality is pretty steep. The only problem was that those mortalities weren't seen in the United States. The operative mortalities in the United States at least 3 institutions that were doing that operation regularly was 4%. So we wondered why there was an increased operative mortality, plus the fact 66% of the patients didn't get all of the therapy they were supposed to get, and there was a lack of pre-randomization stratification. In other words, if you had lymph node disease, would you still get operated on? None of that was done. There was no real pre-surgery staging. So this was interpreted by many of the Europeans that surgery is no good, and especially extrapleural pneumonectomy is no good. Well, let's get back to the staging system. We need to know which patients we can do this on. And staging, grossly at least, is the first way to do it. Turns out that the greater the volume of the disease, the more difficult it is to cure mesothelioma. Duh. But that was in 1998. And they had CT scans in 1998. We had them at the National Cancer Institute, but we also could draw outlines and actually get rough volumes on those patients. And as you increased your volume, you decreased your survival after you did an operation for patients. And you could even show how much disease was left after an operation. And the more disease that was left, the worse you did. So now that's been actually validated by the Boston group, and they actually have this prognostic index, including the hemoglobin and whether you get treated, as well as the tumor volume, as to whether you are going to do okay with surgery. This is just part of a prognostic index. This is one of those, but not certainly the only one. Nodes are important also. By the way, this paper showed that as you increase your volume, you increase your chance of having both lymph nodes within the lung and outside the lung. So greater volume, more lymph node disease, worse prognosis. And then we really didn't have good ways to see if a patient had belly disease or weird axillary metastases, which you see. PET scan helped us do that. So I think that there's been a revolution in how to stage these patients imaging-wise, as well as there's now a validated trial that will be presented at the Society of Thoracic Surgeons that shows that volume correlates with disease survival. Now, we don't have a SEER for mesothelioma, but we have the IASLC IMIG Registry, which essentially is a registry of 2,000 mesotheliomas that was accumulated from all over the world, from at least 50 institutions. It was a surgery-based registry, and we looked to see how patients did, and we looked at the prognostic factors. And stage certainly was one of those, according to the IMIG staging system. Whether you were male or female, females did much better than males. Obviously, epithelial did better than the other types, biphasic and sarcomatoid, younger age, and whether you did the operation to try to do an R0 or an R1 resection, or as good as you can get, or a maximal cytoreduction, whatever you want to call it these days, versus just operating, biopsying, getting out. And in fact, we went ahead and found other factors to add to this in the whole model, which include the platelet count. If your platelet count is up in mesothelioma, you got to be careful. And if your white count is up in mesothelioma, you got to be careful. But most importantly, in surgery patients who get operated on, if you give adjuvant therapy, you do better. Meaning, this is what you do when you don't give, when you have the hazard ratio of not giving adjuvant. So you must treat with adjuvant therapy if you operate on patients with meso. I talked to you about the type of operation. Well, for the first time, there was actually a definition put into the Journal of Thoracic Oncology of what a extrapleural pneumonectomy is versus these type of pleurectomies. This is simply a debulking. A pleurectomy decortication like this is early disease where you don't have to take anything else. But then you can actually spare lung and do extended pleurectomy decortications where you may have to take part of the diaphragm, where you may have to take the pericardium, but you leave the lung in and you do a complete pleurectomy. And that's an extended pleurectomy decortication, which has now become part of the lingo here, and will help distinguish those type of peek and shriek pleurectomies from these extended pleurectomy decortications, which are similar but lung sparing compared to extrapleural. So here's what you can do. Obviously, this is really not the way to go, except in incredibly early disease. This is where most of us go. There are some who use intraoperative sort of stuff with heated chemoperfusion, and that continues, or using povidone or betadine heated perfusion, as they do in the United Kingdom. And then there are some interesting other things that we'll get to that include preoperative radiation therapy. Now, if you give induction chemotherapy and you do an extrapleural pneumonectomy, the median survival is about 20 months. So that's measured from the time, mostly from the beginning of the chemotherapy. So are you really gaining something by doing an extrapleural pneumonectomy and giving induction chemotherapy? Maybe, but the problem is that how you define the length of interval of survival, some people do it from surgery, some people do it from when the chemotherapy starts, will vary. And will also vary as to how many operations these people have done. This is one of the more recent studies that was done from the Swiss group. The Swiss group were the leaders in actually having induction chemo, extrapleural pneumonectomy, and then seeing whether it had any efficacy at all. And this study in 251 patients showed that if you had a long operative time, patients didn't do well. That means more bulk of disease, harder operation, and you shouldn't be operating on those patients. And maybe the C-reactive protein has something to do as far as prognostication, as well as your lung function. So you can do these operations with a 5% 30-day mortality, but you also have to follow these patients out, because what happens here is this: pulmonary embolism. And these people will have pulmonary emboli. Why? Because what happens is their platelet count goes up, and then they get pulmonary emboli in the immediate postoperative period, but it's 30 to 90 days. Now, Valerie Ruch published a paper that showed that if you give extrapleural pneumonectomy and then give postoperative radiation therapy for stage 1 and 2 mesotheliomas, the median survival was 35 months. That was a landmark paper that was published through Sloan Kettering and really was adapted as the standard of care using IMRT, not hemithoracic radiation therapy, after that paper was published. Well, are there any trials that actually have looked at that? Well, this is hot off the press. And this is actually a trial that was done by the Swiss group, in which they did take patients and randomize them to either get or not get postoperative radiation therapy to the empty chest. So if after you give induction and you do an extrapleural pneumonectomy, does radiation therapy make patients live longer? Now, again, you got a lot of patients to start out with, and then you end up randomizing not a lot of patients, because they fall out because of all the staging that gets done for these patients. Well, what do you find? You find that there's no difference whether you add radiation therapy or not. Now, whether this is going to change practice at this point is unknown, but this is a very good group, and this is the group that did probably the biggest induction series in the world. So this is hot off the press, and we wonder now whether post-operative radiation therapy is the way to go. There's the numbers. But interestingly enough, our friends to the north are crazier than we are. In that, actually they had some very good preclinical data. Mesothelioma is absolutely radiation sensitive. And what they did was they said, okay, can we give IMRT to a patient who's going to have an extrapleural pneumonectomy, give it to them beforehand in a quick fractionation, and then operate on the patient, because you can't leave the lung in after you give sort of hemithoracic but IMRT to these people. And how did they do? And what's the mortality? And they published this, and this is from Dr. D. Perot. And essentially, the portals are like this. I mean, you're treating essentially all of the perimeter of the lung. Yes, you do get dose to the lung. That's why you're going to take it out. But this is not for patients who are going to have extended pleurectomy decortications. These patients are committed to have an extrapleural pneumonectomy. The data is quite interesting. And I just was at a meeting in Hawaii, which was a mesothelioma meeting, in which Mark presented an update, because that's now up to about 65 patients. And the data has held. And we wonder about what's going on here. We wonder about antigen presentation when you're doing this. He has actually done some intriguing work where you give CTLA-4 blockade as well as radiation therapy, and shows in an animal model that actually has prolonged survival. So whether you're having some sort of abscopal immunotherapy reaction here, I don't know, but I think it's interesting. But I'm not so sure that everybody wants to do extrapleural pneumonectomies on everybody, because can anybody guess what, if you get a recurrence after an extrapleural pneumonectomy, the median time to death is 5 months. If you get a recurrence after a lung sparing operation, the median time to death is 12 months. So I'm not so sure whether maybe we can modify this to do sort of something like this with pleurectomy decorts, but I'm a little concerned still about going back to routine extrapleural pneumonectomy. So why do I believe that? Well, because this crazy guy did this publication with this crazy guy, in which we combined. This was actually phenomenal, because actually this was the first time you got 3 big institutions putting their data together. Because I personally had done pleurectomy decorts when I was at Carmanos and at NYU as a routine, and didn't believe that you should do an extrapleural on everybody. So we put the data together, and this was the first paper that showed that if you look at all the patients, pleurectomy decorts seem to do better than extrapleural pneumonectomies, and this was stage for stage. So pleurectomy may be just as good as EPP, especially if you have patients with early-ish disease. Now, what is early-ish disease? It's a type of disease that you can actually come out of the operating room and say, I've got a maximal site of reduction, I can't see tumor at the end of the operation, and I can remove all of it off the visceral pleura and get into the fissures, maybe take the diaphragm or not take the diaphragm if it's not involved, and be happy about that operation, and I've saved the lung. And if you really look at how this has changed the practice, you look at these studies from Europe, this is from UK, from Italy, and what you see, these are studies of institutions that did both pleurectomy decortications and extrapleural pneumonectomies, and you could compare within that institution how their patients did. So the same surgeon is doing either pleurectomy decortication or extrapleural pneumonectomy. And in all cases, the mortality was higher with extrapleural pneumonectomy. The morbidity, usually 60 to 70%, is higher with extrapleural pneumonectomy. And the survival in every case seemed to be better, especially in stage 1 and stage 2 patients. So my own feeling is that we should try to do, if we have a patient that's going to go to the operating room for mesothelioma, then we should at least try to see whether that patient has a lung-sparing option, because you're trying to keep these patients going so that they can have further therapies like the Adura trial or the other anti-mesothelin trials that Evan was talking about, because you want to keep these patients in a functional state to be able to put out the fires when they recur. The other thing is, how do you look at a patient and you say, this is a surgical candidate? In other words, how do you decide if you just have minimal information on the patient, stage, platelet, not stage, but whether they're male, female, whether they have a platelet count that's elevated? Well, we actually took all the data from that 2,141 and looked at other supplemental sort of variables, including white count, platelet, age, gender, and histology. And that's all we looked at. And if you combine those, you will see who is the ideal candidate that you should consider for an operation. And you can do your further staging to make sure they don't have disease anywhere else. But if you have a young patient that's female who has epithelial histology with a low platelet count and a low white blood cell count, and their CT scan shows low bulk disease, that may be a patient that you should consider for operation. Now, this is being updated with the brand new database that has now up to 5,000 mesotheliomas, and we'll see if that holds up. So what do? And I've done 300 of them. I feel like when you have early-ish disease like this is pleurectomy decortication, but they get induction therapy. If they have more advanced disease like this, that's the difficult part, because when you start getting this confluence here, then you may have to think about, in these stage 2 operations, an extrapleural pneumonectomy. And in fact, I have one on Monday that may be just that. But this and chest wall pain, be careful. Patients who present with chest wall pain and mesothelioma and they've lost weight and they have high platelet counts, surgeons should beware. So the take-home message is I think that we, as surgeons in meso, are incredibly selective, or we should be. And that sort of is a compromise between what medicine is trying to do and what we're trying to do. Chemotherapy should be given either preoperatively or postoperatively. Radiation therapy postoperatively is under controversy now, and preoperative treatments seem to be promising, but demand at this point extrapleural pneumonectomy. Intraoperative therapy, including both heated perfusion and photodynamic therapy, I started this at the NCI. I think the jury is still out. Now, we'll see, because there's been a lot of changes with the operation we do in these patients, meaning we've moved toward lung-sparing operations. And then in the future, I think we need to think of more window of opportunity trials. And I think that what's going to happen, in fact, the Adura trial with listeria is being thought of now as an induction trial with treatment and then operation to figure out exactly what are the biomarkers and who responds. And that's being worked on. But I think we need more of those type of trials because we got plenty of tumor to do serial biopsies on. Thanks very much.